Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking. Welcome, everyone. I'm your host, Todd Searls, Vice President of Business Development at Caravan Health, and this is Healthcare by the Numbers, a podcast that explores the numbers driving change throughout our industry. To learn more about Caravan Health, this podcast, and to check out episodes of the show, visit caravanhealth.com. And be sure to sign up for our newsletter to be notified of future episodes. You can also visit our program page on Healthcare Now Radio, follow us on Twitter, LinkedIn, and Facebook under our username @Caravan Health. Today, we're talking with Mara McDermott, Vice President at McDermott Consulting, who's a leading health policy consulting firm in Washington, D.C. Mara always knows the latest with what's going on in Washington, and we very often turn to her to understand just what federal officials are thinking, what's coming next on Capitol Hill and at CMS for delivery system reform, physician reimbursement, and value-based payment. In an election year, we think that this is obviously, or I should say, a new presidency, not an election year. This is obviously going to be a very big year for healthcare. And I'm pleased to share today's episode with my colleague, Louise Yinug, Senior Policy Analyst at Caravan, who specializes in health policy for us. Louise, welcome to the podcast.
Thanks so much, Todd. I'm glad to be here.
Well, at Caravan Health, we specialize in helping community health systems transform care delivery, save money, and improve care quality through accountable care. We've been working in alternative payment models since the very beginning and have watched them grow and shift over the years. And Mara, I'm looking forward to our discussion today because these models have grown and we have a new administration. We're curious as to what is next for delivery system and payment reform. So welcome to our podcast.
Thanks so much for having me. I'm excited to be here.
I tell you, Mara's been a friend to Caravan Health for years. We've welcomed her to our annual Accountable Care Symposium to talk about policy, as well as webinar presentations on rural health models. For those of you who haven't had the pleasure of joining in on one of those talks, at McDermott Plus, Mara works with a wide range of health organizations advocating for value-based payment, including the Medicare Shared Savings Program, next-gen ACOs, and emerging programs like direct contracting. She serves as a board member of the Healthcare Cost Institute, an organization shedding light on trends driving healthcare spend across the U.S. And before her current role at McDermott Plus, Mara served as the Senior Vice President of Federal Affairs at America's Physician Groups, which is a professional association representing medical groups and independent practice associations practicing in capitated coordinated care models. And I tell you, we've got a lot of numbers to run through on this episode to help set up our conversation. So Louise, would you do the honors?
I sure will. Thanks so much, Todd. And Mara, we're just delighted to have you. I've worked with you on some of those presentations and webinars in the past, and I know we've always had great conversations. But as we do on all of our podcast episodes, we like to spotlight and really frame our conversation with some of the numbers impacting the industry today. So when we thought about what we've worked on together and the expertise that you bring, we thought about some of the things that have been going on with alternative payment models. So over the past decade, the Center for Medicare and Medicaid Innovation at CMS has tested more than 50 different alternative payment models, and they launched more than 12 in 2019 alone. The Biden administration, which of course just started a couple of months ago, has begun to review all of those active models. And we've seen a couple of the model options already paused for reconsideration. It looks like they're taking a look at what has been launched in the past and sort of figuring out the path forward. The Medicare Shared Savings Program, of course, is one of the oldest of those models and has been one of the most successful. For performance year 2021, what we're in right now, there are 477 shared savings programs, ACOs. This is down a little bit, actually, from 517 in 2020. There have been other fluctuations in the number of shared savings program ACOs, but what's interesting about the drop for this year is it's accompanied by a decline in the number of assigned beneficiaries. It's a little unusual. There were 11.2 million in 2020 and 10.7 million in 2021. In nationwide COVID relief news, just this month, President Biden signed a $1.9 trillion law providing an extension of unemployment insurance, as well as stimulus payments to many Americans, along with tax credits and support for many health providers. That bill includes $8.5 billion for rural Medicare and Medicaid providers, very similar to the HHS Provider Relief Fund that was established a year ago in the CARES Act. It was just, I believe it was just about a year ago that the CARES Act was signed. So those are the numbers.
Well, Mara, you're in contact with many of the key players making news in health policy every day. I mean, which of these numbers or perhaps recent information that you're privy to, I mean, what jumps out at you?
Yeah, a lot. So I'm happy to dive in on that, but I will maybe work in reverse order from what Louise said. You know, obviously the $1.9 trillion stimulus law is a huge deal and provides some relief and is one in a series of relief packages that we've seen since the beginning of the COVID-19 pandemic. And I think, you know, in some ways, HHS has been responsive and has been able to get money out the door quickly through the CARES Act and subsequent provider relief fund distributions. In other ways, many providers are still waiting for that money to hit their bank accounts. And so I think that $8.5 billion for rural is really important. There's still additional money sitting in the provider relief fund, some unknown amount as funds were kind of transferred around in the last administration. I don't think anyone's exactly sure, but there is some additional money, and we're certainly hopeful that that starts hitting bank accounts and getting to people who need it really quickly. So that's my first one. And then working backwards up Louise's list, I would say on the Medicare Shared Savings Program fluctuations in terms of the number of ACOs and the number of beneficiaries, I'm kind of less worried about that overall number. And I would love to maybe come back or continue the conversation around who's dropping and why. And I think that what we have seen, or at least what I've seen with my client base, is much more enthusiasm around risk models as a result of the COVID-19 pandemic, right? So they've looked at health plans and capitated medical groups and capitated ACO type structures and just seen that that has been a much more stable way to endure a fluctuation like the pandemic than relying on fee-for-service payment models. And so, you know, I see what you're saying here about the MSSP overall numbers, but I think there's a little bit more of a nuanced story for us to talk about beneath the surface on that in terms of, you know, where the policy is driving and where the enthusiasm and energy in industry is. And then the last one I would say, you know, sort of that 10-year look back on CMMI and the 50 different alternative payment models. It's not often that I say this, but I'm kind of with MedPAC, right? Like, do we need to start looking at those 50 models, really drilling into what has worked? And I'm not talking about top line evaluation numbers, saved versus not saved, but I'm talking about a deeper analysis. What waivers are working within an ACO? What's not working? How can we tweak and refine the portfolio to better meet the needs on the ground a decade later, right? We've made some progress. We've learned some things. We've learned about benchmarks and risk adjustment and payment waivers. And I think I am hopeful that now is an opportunity for the value-based care movement to take a little bit of a deeper look, a little bit of a pause, and kind of shore up that model portfolio before turning to additional models for 21 and beyond.
Yeah, I would heartily concur with you. I mean, what's worked, what hasn't worked on the ground. And I think I just got off a call actually with a potential client of ours, and what they want to know is about alignment between programs. You know, you have bundled payment programs, you've got primary care first, CPC plus ending. How does that interact with ACOs, be they MSSP or direct contracting as they move downstream? And so you've got this plethora of, you know, of possible value-based care arrangements that they can engage with the government on. But you don't want to double the work, even though you're in multiple programs. You want the programs hopefully to complement one another seamlessly. Do you think MedPAC and others, I mean, that's part of the agenda?
I think so. I mean, I think folks are looking at it carefully. That overlap issue that you talked about has been real and a bugaboo of value-based care for lack of a better word, since the inception of multiple models. And I don't think we're there yet. I do think we're learning and we're getting better at it. And there's still, plenty of work to do. And you mentioned bundles and CPC Plus and primary care first. I think there is a lot out there.
Right.
And a real opportunity to kind of be a little bit more thoughtful about the strategy going forward.
Well, would that tie in nicely to, your experience that you'd like to dig into regarding providers and their willingness to take a look at these programs now, whereas perhaps in the past they weren't? Alignment, I think, would obviously help there. The certainty of payment, definitely in a pandemic, I could see where that would be attractive. But are there concerns that some of the savings and things like that came out of the pandemic were simply because of denied access to care, right? People are locked in their homes, not getting hip surgeries and things like that. Do you think that motivation will continue once, quote unquote, things get back to normal?
I do. So like with anything, right, there's multiple components to the story. And certainly what you're talking about, the utilization fall off, is one component of the story. But what I have seen, and I would venture to guess what Caravan has seen too, is that for providers that made that investment in value-based care or care coordination, sort of setting up data systems and identifying patients and connecting with resources in their local community before the pandemic, as the pandemic took hold, right, they were so well positioned to spring to action. Not that it was easy. I'm not saying that at all. Right. I think it was very hard. But I think they had a leg up in that they had the infrastructure in place, the relationships in place. We've heard our partners talk to us about, if I didn't have this relationship with a skilled nursing facility going into the pandemic, there's no way that we could have set up this sort of triage care and, just had an infrastructure in place, a place to put our COVID-19 patients to keep them separate from the rest of the patient population being treated for other things. So, I think there is enthusiasm around the payment models. I think there's even more enthusiasm around the population health nature of what happened in the pandemic, the ability to rapidly respond, and perhaps most importantly, the ability to really care for your patients who were, maybe frail or had COVID or were nervous about COVID or had other underlying conditions where they couldn't stay away from the doctor for 12 months or longer. So that's what we're seeing. And I think it's going to re-spark the conversation about the adoption of alternative payment models.
That's interesting. We've heard a very similar story when we're talking to our clients about how involvement in an ACO positioned them to get through this just unbelievably difficult year, that knowing who their patients are, knowing exactly what their chronic conditions were, knowing that they had the appropriate patients enrolled in chronic care management and they were already in touch with nurses, just made for so many practices a tremendous difference, even just in being able to switch to, a telehealth based service for patients for whom that was appropriate. So it's good to hear that has been an experience for other value-based payment providers as well. I did want to ask, of course, you are a Washington, D.C. expert, and we are in a new Congress and a new administration. And we, of course, with the passage and the signing of the relief law, we sort of saw that at work, right? We have a new administration that wasn't concerned about really going for its priorities and being able to use the reconciliation process to pass this pretty enormous and far-reaching bill. I'm wondering what you are seeing as the prospects for value-based payment in this new Washington. Can you talk a little bit about that?
Yeah, I'm happy to. So it's an interesting time for value-based care policy because so much of the wind in Washington, or so much of the air, I guess I should say, has been absorbed by COVID relief and economic stimulus, right? So we've seen a lot of conversation about a minimum wage or subsidies and things of that nature. And as is always the case, the value-based care conversation is technical and it's hard and it's not really like, it doesn't really roll off the tongue, right? ACO benchmark isn't coming to you at cocktail parties and things like that. But, I think this administration is serious about continuing the value-based care initiatives that were really in many ways started by the Affordable Care Act under Barack Obama and Joe Biden, and many of the political officials that we talk to in the administration, I think, want to continue that legacy and make sure that commitment to a more sustainable Medicare program and more sustainable, higher quality offerings for folks involved in federal healthcare programs is part of the legacy and is part of the future. So I think we'll see a resurgence of that type of policy, as we start to move into the recovery phase, once we've got more adults vaccinated, once there's some time to really think about things other than COVID-19. On the Hill, what I would say is, for our audience, if you're in a value-based care arrangement, you're in an accountable care organization, I would just urge you to talk to your member of Congress about it. The staff, pretty much anyone who will listen, local, national. I think there's just a real lack of understanding of what it is on the Hill. And we can all do ourselves a favor by continuing to do that education and talk about, not just I'm in an accountable care organization, but what does that mean? What does that mean for patients? What does that mean for providers? And really telling those stories, which I know are out there, about patients who are having coordinated care for the first time in their lives, and it's making a remarkable difference in their experience. So that's what I got on tap, Louise.
That's great to hear.
Yeah. And I think what you just touched on is what makes us get up every morning, right? We hear the population health nurse success stories, and it seems like, right, we go through these swings in healthcare where it's focused on the patients, then it's focused on the dollars, and the patient somehow gets, a back seat to it. And value-based care is trying to keep them both front and center. And you mentioned, right, we should be reaching out to our local legislatures, associations, hospital associations, medical associations, whoever will listen, about how this can continue a good patient-centric focus. But we do have a new administration. We've got new state senators, new federal Congress folks coming in. Do you think that there are certain leaders who totally get it, and you think it's going to be, cornerstone legislation for them moving forward? Or is it, once again, everybody is, now suddenly going to become aware of our deficit, and for 4 years, that's the only thing that's going to see any headlines and movement?
Well, I hope not. I hope that we're not just talking about deficit for the next 4 years. I think there's some real opportunity legislatively. To your question, I think there's an existing bench of champions in the House and Senate. Certainly in the House, the Healthcare Innovation Caucus, which was formed to address these types of problems and issues and be thoughtful about how to drive innovation forward. Both, sort of payment models, but also other things, right? Drugs and devices and other regulatory barriers. And then in the Senate, I would say there are a handful of senators who really are committed to advancing value-based care. But beyond that, I think, we're really reaching a time where we can start to think about what the next iteration of the Medicare Access and CHIP Reauthorization Act, MACRA, looks like. As you both know, that law created a series of incentives and penalties intended to encourage the adoption of alternative payment models and pay for performance in traditional Medicare, so fee for service with an adjustment for quality and cost, and adoption of interoperable health records and things of that nature. And I think there are members of Congress who are interested in at least starting to think about what that looks like, and how do you continue legislatively to drive the adoption of alternative payment models. So I remain hopeful that we're going to have legislative opportunity, perhaps the chance to extend some of those MACRA bonus payments for those who have adopted alternative payment models, and otherwise just revisiting, what do the carrots and sticks look like? What does the model portfolio look like? And what are our next steps?
And I appreciate hearing the perspective of what we can expect from the Congress. I'm wondering I know many of us, I live in Washington, you live in Washington, but many people who listen to this podcast probably don't. Can you remind people who are coming in as the leaders in HHS, what names we should be looking out for, and what we can expect in terms of direction from these new incoming officials?
Absolutely. So we've got a few new officials coming in. Many more that I'm going to talk about today. I'll kind of focus on my personal big three. So the first is the incoming Secretary of Health and Human Services, who I believe was confirmed yesterday and sworn in today. So very exciting. Javier Becerra, and he has a long history in public service, was a member of Congress, has been an attorney representing the Affordable Care Act in court and the states that wanted to protect that law, and now takes the helm at HHS, and I think will be a very thoughtful partner in terms of our objectives around value-based care. Has been very focused on the coverage conversation, which I think is going to continue to dominate, right? Like, especially as we have more and more people who have lost or are losing their insurance as a result of the pandemic. But I think will be a good thought partner and good leader on the topic of value-based care as well. The second that I would mention is Chiquita Brooks-LaSure. She likewise spent a lot of years in government service and has a strong background in that coverage policy. I think for her, again, a good thought partner, very smart policy person who will be interested in the future of value and the value models among the other issues in her portfolio. Again, very well versed in the Affordable Care Act and Medicaid. And I think these picks indicate where President Biden is going to be applying a lot of focus in the first couple years. Not that value will be off the table, but I think that coverage conversation is really going to dominate. And then my third name in the news is Liz Fowler, who recently, just earlier this month, became the director for the CMS Innovation Center. And she likewise has had a long history in government service. She spent some time working on the Hill, is familiar with the value-based care portfolio, has written in the past about models like geographic direct contracting, and I think is just going to be a wonderful, thoughtful leader of CMMI. And we are certainly looking forward to working with her in her new capacity.
Well, and you just mentioned the direct contracting. We know every new administration comes in and likes to reassess, I think would be the polite way of saying what the previous administrations have done, to put perhaps their own fingerprint on it. And I know direct contracting, primary care first, and perhaps some other value-based care arrangements are being looked at. Have you heard anything about that? Do you think that we'll see this, dynamic shift away from the way certain value-based care arrangements like direct contracting with the GEO model and things like that? Do you think we'll see a dynamic shift away from it, or just tweaks on the edges as written?
Yeah, I would differentiate, I think, among those different things. So as your listeners probably know, in direct contracting, you've got some different options. There's a professional risk and a global risk, which CMMI has been shorthanding as GLOPRO, which I just think is really funny. It makes me think of that little camera.
Yeah, love that acronym. I just know people say government isn't inventive, but you know what? That really is. I like that.
I know, right? So that GLOPRO to me is very similar to a next-gen ACO. I mean, there are some nuances and differences, but by and large, very similar. That model is on track. So their participation agreements came out maybe a week ago with their April 1 start date as planned, moving forward, chugging along. I think there will be tweaks around the edges on that one. I think there are some improvements that need to be made, but largely that goes forward. The geographic model, to your question, or maybe more to your point, is different to me. And I have a harder time seeing that one go forward as currently structured. So the idea there, just to kind of level set, was that a party, it didn't have to be a provider, or somebody would take risk for a geographic area and work with ACOs and contracted providers to organize that market. And a big defining feature of the geographic model was random attribution. So for beneficiaries who don't have that care relationship through claims history or through an election of a main doctor, they would be randomly attributed to one of several geographic entities in that area. And to me, that always seemed like a heavy lift. Not that it's not possible, but that it needs more conversation and more buy-in from beneficiary groups and provider groups, and that you'd really want to bring a lot of different people to the table to have that conversation if you're going to take on that level of risk and potential reward. Mm-hmm. So I think that one, I would put that one in a slightly different bucket, like more potential for changes as opposed to tweaks around the edges. I think it can still go forward. I don't think it's like a lost cause for those in the audience that are excited about it. Maybe that's good news, but I do think it needs some more input from stakeholders and some more work from this administration in terms of how they want to roll that out.
Yeah, it's interesting to me in terms of, as CMS announces these, do you think that when they pause a certain section of these programs, it slows the adoption of the entire program? Or do you think those paying attention know enough that they're going to move forward irrespective, take advantage of those programs that are beneficial to them, even if, half of what was originally planned for gets paused?
It's a great point. I think there is a lot of confusion. And I, to your point, I don't know that people are so carefully watching global versus geo versus professional, primary care. I have said to CMS many times, I think we need a statement of direction, right? Whatever that is, figure it out. But can you tell the signal to market where it's going? And even with the geographic model, I think what it says on the website is CMS is reviewing it. Well, what does that mean?
Right.
And when is it coming? When? So I think there's some more to do there to just remind everyone that we're all in this together and to articulate some of that direction and timing, right? We're reviewing this and it's not going to start 1/1/22, or we're reviewing this and we'll have an update for you in 3 months. A little bit more information to your point would be very helpful.
Agreed.
Absolutely. And of course, a lot of our clients are looking to see what might be going on with the chart rural model with the 2 tracks there. And one of them, the community transformation track, where we have more information. I believe the application deadline was just extended, which could be good news for individuals that just hadn't gotten around to completing the application paperwork. But you also do wonder whether there's also a signal behind a delay like that. And of course, I know many of our clients are eagerly awaiting more information about the ACO track because it's so similar to the ACO investment model that we were so successful in several years back. And we are very confident that we'll be able to be successful again once we know what the details are and we're able to get more rural providers signed up. So people are very eager, and I like the idea of CMS issuing a sort of statement of what's going on here. That's not exactly the term you used, but but I like the idea.
Yeah.
I think we might have time for one more question, and I'm really dying to get back to something you said at the top of the program, Mara, which is we were talking about these ACO numbers, about the dip in the number of ACOs for the Shared Savings Program, as well as the dip in the number of beneficiaries. And I know a lot of people who are interested in this stuff are trying to read a lot into those numbers, right? What does this mean? Is it COVID related? Of course, CMS, because of the COVID public health emergency, actually canceled the application season for 2021. And so there was just a lot of, I think, in other words, ACOs were just extending for 2021. But also there is a faster path to risk under pathways to success. I think people are trying to read into these numbers, but I think you had said there may be a more nuanced story that you think is behind them, if I heard you correctly. So I'm just curious if you can spell that out a little bit more and flesh out your thoughts behind this.
Yeah, at the danger of talking off the cuff with Louise. So I
sorry,
no,
I did take
you're
notes.
Good. You're good.
Apologies.
Yeah, no. So I'm happy to add a little bit more color there. I think, and I'm curious if you agree with this, but I think that there were organizations early on in Medicare Shared Savings Program who got into ACOs for a wide variety of reasons, right? Some of those reasons were that they wanted to coordinate care and, do the right thing and try to align their population. Other organizations, I think, got into the ACO movement because it was a cool thing to do. It's like a thought leadership thing, or, and they didn't have to take downside, to your point, and there were robust waivers in place, fraud and abuse and otherwise, to encourage adoption. And so I guess what I would like to know about those numbers is a deeper dive. I mean, are we losing ACOs who were really ACOs in name only, who, maybe didn't belong in that program? Maybe they belong in a different value-based care program. Or are we really losing ACOs because they're saying, I want to move to risk, but this is too much too fast. And so rather than try to hang in there, I'm going to leave. And I think that is, sort of the story that I would like to know more about, which is, sort of why are they leaving? Are we assuming that they're leaving because the risk level is too high, or do we know that for sure? And if that's the case, what are the policy adjustments that we can make to get people back on that ramp to risk? I think the other thing is, through these programs, you see some attrition, right? Like you look at Next Gen, and I think it was a high of like 57 or maybe even more, and now we're down to about 40. I think some of that is just like a natural fluctuation in any experiment. And so I'm reluctant to get myself to a place of total despair about the value movement based on these fluctuations yet. I could be convinced, but I'm not there yet.
We're not doing despair in 2021.
No.
No, I appreciate that perspective, and to see the different, you talk to providers going into value-based care all the time. And so to think about it in terms of those categories, right, that some were just doing it to do it and some were a little bit more serious about it, I think is an important way to think about it. Because of course you're going to have attrition among providers who maybe didn't understand what it takes to really transform care. Because of course there's going to be some of that when you're looking at these enormous numbers. It's an enormous number of providers and beneficiaries in these programs. So of course there's going to be some of that. So that's important to keep in mind. Thank you.
Yeah.
Well, Mara, I know we're running close to our time limit here. Do you have any final thoughts, any parting comments?
Yeah, I would just say, stick with it, stick with the value-based care. I think we are going to enter a little bit of a slowdown in time around just like the pace with which we've seen these models adopted. You guys have heard me say, because we talk a lot, that I think over the last 4 years with Adam Bowler and Brad Smith, we really had this time of invention, right? Like we had two guys who were inventors who were coming out with new models. And I think really quickly you saw kidney and direct contracting and primary care first, and oncology, discussion about oncology care first. And I think we're headed into a period where we're more sort of like tending to the value-based care garden, and getting out our fertilizer and our clippers and starting to get to work in terms of, what's working and what's not working and where do we need to reinvest. And I think it's going to be an interesting time and a time full of opportunity for value-based care growth, but a little bit different than where we've been the last 4 years. And the final thing I'd be remiss if I didn't mention is, I think we're going to really see a focus that we haven't seen before on equity in value-based care models. And, how are these models being responsive to the needs of communities and making sure that we're getting to patients who maybe don't have a regular source of care and need coordinated care and haven't been able to access it in the past. And that is something that I am really looking forward to. I know a lot of our providers and your providers have very creative solutions for reaching hard to reach beneficiaries and improving the care of their local communities. And I'm excited for this next chapter.
Yeah, I am too. I have to say, over time, right, back when macro was first released and we had meaningful use, there seemed to be a lot of initiatives that didn't focus on the disparate communities of care that actually exist, right? It seemed like it was great for the Beltway or for the large urban areas, but a lot of people didn't realize it could be, Nebraska, where I'm based out of, is more cows than, people. And it's 9 hours from one corner of the state to the other. And getting to care in our rural areas is sometimes very difficult. So to see care models that understand that, or in food deserts or in behavioral health deserts where there's just not access to that level of care, to see those things focused on, like you had said, what such a great analogy about caring for the garden that we've already planted, pulling the weeds out, but letting the true opportunities, true flowers bloom and grow and get bigger. I really do look forward to that time. And I hope this next 4 years is that time. Well, Mara, thank you for joining us today. It has absolutely been a pleasure, as always, having you on Healthcare by the Numbers. For our audience, if you'd like to learn more about Mara and her work, you can follow her on Twitter and LinkedIn at Mara McDermott. That's MaramcDermott. For Louise and I want to thank everyone for listening today. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.